Hello and welcome to this webinar for World Continence Week in 2023. My name's Gillian McCabe. I'm a clinical specialist pelvic health physiotherapist based in Cardiff in Wales in the United Kingdom. I work in private practice specifically for pelvic health issues. So the webinar today is about managing pelvic floor muscle dysfunction following vaginal delivery and the role of maple in this. So in this webinar we are going to be looking at all the things relating to pelvic floor dysfunction and vaginal deliveries. I'm going to tell you a little bit about myself. Some of you might know me, some of you may not. I'm going to go through some of the definitions that I use in this presentation so we're all clear on what I'm talking about. Then we're going to talk a little bit about the prevalence and the risk factors, and then the guidelines for management of pelvic floor dysfunction following childbirth. And then I've got 4 cases looking at the role of maple in pelvic floor rehabilitation after childbirth. Case 1 is a von Tu's delivery with symptoms of prolapse and pain. Case 2 is relating to a forceps delivery with symptoms of stress urinary incontinence. Case 3 is a lady who had an elective caesarean section but does have symptoms of urinary urge incontinence and coccydynia. And then case 4 is a 4th degree tear, obstetric anal sphincter injury with bowel urgency and bowel incontinence. And then we're just going to sum up with a small conclusion. So let's make a start. So a little bit about me. As I said, my name is Gillian McCabe and I'm based in Cardiff in South Wales in the UK. I studied in the University of the West of England and received a BSc Honours in 2004 for physiotherapy. I then moved into the Welsh NHS, mainly based in Cardiff and Vale NHS, and specialised in pelvic health in 2006. I then worked towards a master's degree in pelvic health physiotherapy from the University of Bradford and achieved this in 2015. I also started working part-time in private practice, starting with assessment and treatment in people's homes for pregnancy-related conditions from about 2008, and then in 2016 and early 2017 I incorporated Gillian McCabe Physiotherapy for Women, which is my physiotherapy clinic in private practice, and in January 2017 I moved from the NHS and worked solely in private practice. I've been a maple user since 2019, so I'm definitely not the guru or the expert, but I have some cases that I can bring to this webinar that might be useful for information and discussion. I've also created Reconnect, which is a series of online patient training. This started in 2020 as a project during lockdown and has grown since then. And then in 2022, myself and my husband opened up Station House Health and Wellbeing, which is a multidisciplinary centre for not just women, but for anyone dealing with health and wellbeing issues. We rent out rooms to healthcare practitioners and also run our physiotherapy practice from there. So here are some definitions that I'm going to be using in this webinar. So pelvic floor dysfunction, PFD, we're talking about stress urinary incontinence, overactive bladder syndrome, that would include urgency and urge incontinence, pelvic organ prolapse or POP, and pelvic pain, fecal incontinence, and also flatal incontinence as well. In terms of the degrees of perineal and pelvic floor trauma, 1st degree tears, we are talking about small skin deep tears which usually heal naturally and sometimes need sutures but most often don't. And 2nd degree tears, a deeper tear affecting the muscle layer of the perineum as well as the skin. Those usually require sutures or stitches. And then episiotomy, a cut or incision through the area between the vaginal opening and the anus, usually in the perineum. In my experience tends to be right mediolateral and differs in depth and length. And then OASI, obstetric anal sphincter injury, so 3rd or 4th degree tears affecting the anal sphincters to varying degrees. So we're just looking at some of the evidence around method of delivery or mode of delivery and the risk of pelvic floor dysfunction. So there's a really nice article from 2018, Blomqvist et al., looking at the association of the delivery mode with pelvic floor dysfunction after childbirth. And they looked at over 1,500 women. 778 of these were delivered by caesarean section, 565 vaginally, and 2,887 total deliveries. Of these, 28% had 1 delivery, 56% had 2 deliveries, and 16% had at least 3 deliveries. And you can see here in the graphs the findings from their study. So you have the dark blue line as an operative vaginal birth, the bright sky blue line as spontaneous vaginal birth, and then the orange line as a caesarean section. And you have the top left graph is looking at stress urinary incontinence symptoms, and then top right overactive bladder symptoms, bottom left anal incontinence, and bottom right pelvic organ prolapse. And you can see there that they are looking at from the point of delivery, and they reviewed these individuals up to 20 years after their first delivery. And they are looking at the cumulative incidence of pelvic floor dysfunctions. So they've got the individual pelvic floor dysfunctions there and the effects or the links with the type of delivery. And you can see that over time, to varying degrees, the incidence of pelvic floor dysfunction increases. So whether that's stress incontinence, overactive bladder, or anal incontinence or prolapse, those incidences increase. But you can see that the top line is always the operative vaginal birth. So we're talking forceps or Ventouse or vacuum extraction. And you can see there that vaginal deliveries are just below, and then caesarean sections have some level of protective nature at delivery, but there is still an increasing incidence in all of these PFDs by the 20-year mark. Memon and Handa have said in their article, which was a USA study, that pelvic floor dysfunction is 3 times more common in women who have had children than women who have not had children. And a Swedish study by Hallock and Handa in 2016 noted that 46% of women in their study had at least 1 pelvic floor dysfunction. And the pelvic floor dysfunction that they experience usually occurred after their first vaginal birth. There is a strong association with vaginal delivery, urinary incontinence, and stress urinary incontinence. And interestingly, up to 80% of the women that they studied had proven nerve dysfunction after the delivery, but that had resolved in the majority of cases by 1 year after the delivery. Another Swedish study in 2021 has shown that 80% of the women that they studied experienced perineal laceration. 40 to 50% of lacerations involved the pelvic floor muscles, so were 2nd degree tears or above, and 7% experienced obstetric anal sphincter injury. And then a study from Italy and Italian-speaking Switzerland noticed almost 50% of the women they studied experienced a pelvic floor dysfunction, and bladder symptoms were more prevalent in the pregnancy than postnatally. A more recent study from 2023 by Wu et al. Looked at 1,500 participants at 6 to 8 weeks postpartum. And they were looking at the electrophysiological findings of the pelvic floor. So of that study, 84.1% of the women that they studied had at least 1 pelvic floor dysfunction. almost 80% had an anterior prolapse. Now remember, this is 6 to 8 weeks postpartum, so a lot of change can happen between that point and even 3 to 6 months after the delivery. 13.5% of the women had posterior prolapse, and 7.8% had apical or uterine descent. 18.8% of the women had urinary incontinence in pregnancy, and 11.8% of the women had urinary incontinence postnatally. But what is really interesting is, of those tested for electrophysiological changes in the pelvic floor or abnormalities in the pelvic floor, 95.2% were showing abnormal findings at 6 to 8 weeks postpartum. So the NICE guidance from 2021 has shown these areas of risk factors for pelvic floor dysfunction related to childbirth and general lifestyle factors. So on the left-hand side, you can see the modifiable risk factors of body mass index over 25, smoking, lack of exercise, constipation and diabetes. And then specifically related to pregnancy, being over the age of 30 years when having the baby, and having any children or having had any children or given birth before their current pregnancy. And then related to labour, assisted vaginal deliveries, so forceps or vacuum extraction, a vaginal birth when the baby is lying occipito-posterior, an active second stage of labour taking more than 1 hour, and then injury to the anal sphincter during birth. So these are the risk factors for pelvic floor dysfunction, and this can be a really nice screening tool at delivery and during pregnancy to see whether women should be referred for prevention and rehabilitation of their pelvic floor to hopefully reduce the incidence of pelvic floor dysfunction either postnatally or even later in life. The NICE guidance have also recommended the following in terms of management of any pelvic floor dysfunctions related to childbirth. They've said that it's important to raise awareness of pelvic floor dysfunction and the risk factors and how to prevent problems in the future. They've talked about clear communication and providing information to each individual, ideally before pregnancy, but definitely in pregnancy. And then assessment in primary care, so that would be in the NHS in the UK, ideally, and then they've got some guidance there on non-surgical management of pelvic floor dysfunctions, which we're going to look at a little bit more closely now from a physio perspective and from a perspective of using MAPLE. So the NICE guidance has recommended digital assessment of the pelvic floor and pelvic floor muscle contraction and relaxation. Now this can be done in pregnancy as long as there are no contraindications and can be completed throughout the different trimesters of pregnancy and then postnatally as well. NICE have also recommended that a pelvic floor muscle training program should be not only supervised by a physiotherapist or a healthcare professional with expertise in pelvic floor training, but also should be tailor-made or bespoke to the individual that is dealing with that pelvic floor dysfunction. And this is where physiotherapy, pelvic health physiotherapy comes into its own, and also MAPLE can become even more effective and useful. So in terms of the supervision, we need to be looking at each individual. So not necessarily group sessions, although that can be useful for information giving and dissemination. But in terms of pelvic floor rehabilitation, there needs to be an examination of that individual's pelvic floor. And we need to find as much detail of the pelvic floor dysfunctions that are or are not present at that point in the pregnancy or postnatally. And having a tailor-made pelvic floor muscle training program is essential to good rehabilitation and even prevention of problems into the future. and it's important that the women complete the course to get the benefits that we are expecting with pelvic floor training programs. And this is where Maple can come into its own in terms of the feedback that the patients get during assessment and during their training program. So moving on then to the role of Maple in especially postnatal assessment and treatment of pelvic floor dysfunction. I see Maple as a useful tool in the assessment and treatment toolbox that a physiotherapist owns. So as we become more and more experienced and we receive more and more training and we become more and more up to date with physiotherapy treatment modalities, our toolbox tends to get bigger. So we have more options for assessment and treatment, and I see that Maple fits into that toolbox really, really well. So we have digital examinations, we have the Maple, we have real-time ultrasound scanning, maybe dynamometry, we have our own observations and palpation externally and internally, and we can use all of these tools and treatments to help the woman as an individual achieve her goals of removing pelvic health concerns and complaints postnatally. Now, the Maple is sensitive and accurate. It provides electromyographic assessment findings of each individual muscle within the pelvic floor. Another positive is that it has a very thin probe, which is pretty much finger-sized, that might be more comfortable for the patient, either vaginally or rectally, following delivery. It's important for the patient to not feel that inserting something vaginally or rectally postnatally is something that they have to fear or is a barrier to their rehabilitation. So the thin probe can be something that is very beneficial in that early postnatal period. Using Maple as an assessment of predictive factors for pelvic floor dysfunction later in their postnatal journey can also be very useful. So we can use the Maple device, and this is used in my private practice quite regularly for women who maybe have delivered and are coming for a routine screening to see if they have any problems despite the absence of symptoms of pelvic floor dysfunction initially after delivery. We can use the Maple device to screen for any possible dysfunctions or anything that's out of the ordinary, that's abnormal, that could be treated as a preventative strategy. And Maple provides that information along with the other physiotherapy assessment tools that we use. Maple is very sensitive in its assessment, so we can look at any asymmetries relating to the pelvic floor, possibly lack of activity or increased activity around a scar. We can look at overactivity towards the back of the pelvic floor compared to the front. We can look at differences from right to left. We can look at each individual muscle within the pelvic floor quite easily with one assessment. Maple is also very, very useful in pain management after childbirth. A lot of women experience vaginal pain, anal pain, difficulty sitting after delivery, and the electrical stimulation function of the Maple device can provide some really useful pain relieving strategies to help reduce the pain but also improve function and reduce adaptive strategies or compensatory strategies that may cause more pelvic dysfunction in the future if it wasn't treated initially. EMG biofeedback is also a really useful tool in helping the patient to reconnect with their pelvic floor. Sometimes after traumatic birth, the patient can become disconnected from the pelvic floor, and the use of the iPad and the screen and the feedback and the guidance from the physio can be very useful in reconnecting the patient, mind and body, back to their pelvic floor. So just a little refresh about Maple. So this is a unipolar EMG assessment. There's a small probe with 24 gold electrodes. and the electrodes sit on individual muscles, and they look from superficial to deep, right to left, front to back. The Maple screen on the iPad provides a 2D grid to see the activity levels of each individual pelvic floor muscle, and there is also a line graph view that is quite often seen in EMG biofeedback from a bipolar perspective. So the grid is the main differentiating factor from what is available on the market aside from Maple. There's an electrical stimulation capability for improving muscle function and also for pain relief. And there's also a filtering capability for EMG assessment and treatment, so that we can hone in the assessment or the treatment to specific areas or specific muscles within the pelvic floor, making that treatment as effective and as pinpoint as possible. The Maple electrodes have been approved by MRI in terms of the location where they sit, so we can be confident that when we are using the filtered approach with Maple, that we can be accurate in the treatment and the assessment of individual muscles within the pelvic floor. So here we have the view of the 2D grid. So on the left side of your screen you have a vaginal view, and on the right side of the screen you have a view if the probe is inserted anally. So looking at the 5 left-handed pictures there, you can see that the outer rings of the grid circle are the more superficial muscles of the pelvic floor, and the rings that are closer to the center of that circle are the deeper pelvic floor muscles, the levator ani. There is a lighter blue colour in the urogenital diaphragm and the anal canal, simply because we cannot be completely specific of which muscle we are dealing with vaginally on the anterior or posterior plate. And then on the right hand pictures there you can see that the external anal sphincter is shown by the outermost ring, ring 6, and then those muscles move inwards towards the deeper sections of the anal canal as you get closer to the centre of the grid. And again, the urogenital diaphragm and vagina on that anterior plate in the top right hand picture is in light blue, because we cannot be completely specific about which muscles are providing the feedback for that area on the plate. So we're going to move into the 4 case studies. Our case number 1, we have Laura, who is a 38-year-old female. She's had 2 pregnancies and 1 delivery. She had 1 miscarriage at 24 weeks. Her most recent delivery was a Ventouse vacuum extraction, vaginal delivery and episiotomy. She also had some internal vaginal tears. There's some confusion over where those internal tears were, but from her notes it seems that they were possibly anterior and near the urethra, which ties in with some of her symptoms. She also had a 1.5 litre postpartum hemorrhage, which seemed to affect her haemoglobin levels and affected her ability for scar healing post-delivery. So her episiotomy scar in particular took a long time to heal. It dehisced, it became infected, and healed by secondary intention. She has really struggled with pelvic floor recovery after delivery. Her main symptoms when she first came to see me, sensations of urethral tugging and soreness when walking longer distances and when relaxing the pelvic floor squeeze. She had a sensation of sore bulging vaginally when walking for longer distances, and after she had opened her bowels were quite uncomfortable for up to 2 hours, specifically around the anal sphincter and around the left side of that anal sphincter. So you can see here we've got the summary grid assessments here. So we've got session 1 on the left-hand side, and then session 12 on the right-hand side. So this lady so far has had 12 sessions of Maple on a weekly basis. And the main findings here, you can see in the left-hand screen that there are quite low-level activation shadings in the central grid for MVC, which is maximum voluntary contraction. These are your fast fibre muscle contractions of 3 seconds. And you can see there that on the initial assessment there was very little going on. Her peak EMG was 6.5 microvolts. Ideally that would be above 16 or even higher than that. And we would ideally see much more of the darker shading into the dark greys and even the black colours throughout that grid. During that initial assessment, we did not check the endurance, mainly because it was felt that the patient would feel demotivated from the findings there. Now you can see on the right-hand side the changes in the grid. You can see there that there is an increased activation throughout by session 12 without an major increase in resting tone. There's a slight increase in resting activity, but not a major increase. The MVC findings, so on the right-hand image, the central grid, you can see that the posterior plate is now showing signs of good and sustainable activity throughout the fast fibre activations, and that right plate, where the episiotomy was or is, has started to increase activation. On the far right grid, you can see that on endurance, her ability to activate throughout the pelvic floor, and especially through that right plate where the episiotomy scar is, has greatly improved. Now, we can see there that there is a difference between her ability during MVC to activate throughout the grid and her ability during endurance. So although her peak EMG score is 16.2 on MVC, and her peak EMG score on endurance is 18.6, the ability to co-activate throughout the pelvic floor muscle team is reduced during MVC. So that's something that we're going to work on from now onwards, so from session 13 onwards, to try and improve her ability to activate more of her pelvic floor muscles during the MVC fast fibre work. So our treatment program started with Maple, with electrical stimulation, with a focus on improving the fast fibre activation and improving the patient's perception of movement during a pelvic floor squeeze. We then progressed the electrical stimulation to combine both fast fibre and slow fibre activation in one physiotherapy session. And as the client became more able, she progressed to EMG biofeedback training, using the training module on the Maple device so that she could see how much she could activate her pelvic floor. We also, through this session, combined the Maple treatments with manual therapy vaginally to release off tensions through the posterior left levator that seemed to be quite sore and uncomfortable, and on examination seemed to be tight and restricted, and also some scar tissue massage through the episiotomy site. The client also used a Kegel 8 machine and still uses the Kegel 8 machine at home to improve the carryover of treatment from session to session. Here you can see the case study 1, so Laura's maximum voluntary contraction progress. So you've got session 1 on the left and session 12 progress on the right. And it's quite clear there on the line graph that you can see that there is a noticeable improvement in her ability to activate more noticeably within the grey boxes. So on the left, the activation reaches a peak of between 6 and 8 microvolts, and on the right you can see that her activation reaches between 14 and 18 microvolts. So if we were to simply look at the line graph, we would say that pelvic floor has improved dramatically. But as you remember from the grid, although her pelvic floor ability to activate is improved, the teamwork within that pelvic floor unit is not optimal, and so ongoing treatment is required. So that shows that the Maple grid view, which is unique to the Maple, is extremely important in improving that treatment planning and progress monitoring. Her resting activity in between the MVC contractions has increased, but we're not too concerned by that because her discomfort is reducing and her symptoms are improving, but we are monitoring this. And here you can see the same progress of the endurance fibres. So initially she was only able to hold for the 15 seconds, and then by session 12 on the right you can see that she's holding for the 30 seconds. So that is an improvement, and you can see a noticeable improvement in her ability to activate to higher microvolts. So this shows again a noticeable improvement. So here you can see this lady's symptomatic progress. So on the left we have her initial symptoms of urethral tugging and soreness, vaginal bulging, bowels being sore after emptying, requiring perineal pressure to be able to empty her bowels, and feeling the need to manually push rectal tissue back into the anus after emptying her bowels. So following 12 sessions of Maple, her experience is now that the urethra feels more supported and feels less sore when she's out walking. She's even been able to walk on the coastal path, which is uneven ground, which initially she felt she would never be able to do again. She feels more supported vaginally and not so aware of the vaginal bulge when out walking. She feels she can walk for longer distances. Her bowels do feel more settled, but she is awaiting a colorectal assessment for a second opinion relating to possible rectal prolapse. She's generally feeling more positive about returning to exercise and weight training and running. And her testimonial on session 12 is that Maple has been very useful in helping her to understand what's going on in her pelvic floor and how the dysfunction relates to her symptoms. The feedback and the noticeable effects of the stimulation have been really encouraging. She feels more positive about her future and even the prospect of having another baby. So here we have case study number 2. Rhiannon is a 40-year-old female who has had one pregnancy and one delivery, and that delivery was a forceps vaginal delivery with episiotomy. The baby's weight was 8 pounds 12 ounces, and her scar healed well, but it felt tight for months after the delivery. Her main symptoms on initial assessment was stress incontinence with sneezing and exercise, especially at attempts to return to impact training. So she enjoys CrossFit and she enjoys running outdoors. She also has the symptoms of prolapse, of a rectocele, posterior wall vaginal prolapse with incomplete bowel emptying. And she also wanted to be assessed and managed for diastasis rectus abdominis and doming of the lower back, doming of the abdomen and lower back pain. On assessment, her diastasis was more noticeable below the navel, so between the navel and the symphysis pubis. So we've used Maple vaginally here for assessment and rehabilitation for this lady. And again, you can see session 1 is the assessment, and then on the right hand side, session 10 is her progress. Initially, on the left hand 3 grids, you can see that at rest, her resting activity is slightly higher than the ideal 2 microvolts, but not too high. She hasn't had any pain or any problems with intercourse, so we haven't focused our treatment on that. And we can see with the MVC, so the maximum voluntary contraction, that she is able to produce a peak EMG of 9.5 microvolts, which isn't bad, but could be a lot better. but most of that activity is coming from the deep right levator, so coccygeus, and a little bit of puborectalis on that right hand side. There's very little activity elsewhere in the pelvic floor during MVC, and then during the endurance she's able to increase her peak EMG to 11.8 microvolts, but again, in terms of the teamwork, we are looking at right coccygeus, partially puborectalis, and then bulbospongiosis on the left. So that, in terms of the grid, does not look functional. And then as you go across to session 10, unfortunately the resting assessment didn't save on that assessment day, but there was no issues with her resting activity. But you can see a general increase overall throughout the MVC, and she is able now to reach a peak of 17.5 microvolts, but again there is more activity through the right than the left. So we're still working on trying to improve the coordination of activity during MVC. But you can see on the endurance that she is now able to reach the same peak EMG, so 17.4 microvolts, but the teamwork has greatly improved. And she has activation from superficial to deep and right to left, with a slight reduction on the left compared to the right, but nothing too noticeable. So ideally we would like to get that level of teamwork during the MVC assessment findings. So the treatment program started with electrical stimulation, again focusing initially on fast fibre activation, and specifically trying to activate the posterior and left plates of the maple grid. The electrical stimulation then progressed to combining fast fibre and slow fibre activation in a session. So we do a fast fibre activation treatment and then a slow fibre activation treatment before we reassessed. And then we progressed to including EMG biofeedback training to try and improve the client's ability to activate throughout the pelvic floor team. And she also progressed to using electrical stimulation at home for maintenance of the pelvic floor muscle activity with a Kegel 8 machine. And she also added a PeriFit smart pelvic floor training device, which uses pressure sensors rather than EMG. And you may have seen it advertised online, you may have experience of it, but it provides games that you can play using your pelvic floor muscles to try and improve the function of the pelvic floor team. So here we have the same case, her MVC progress on the line graph. And you can see there that despite a little bit of feedback on that left hand side at one point, for whatever reason, overall her activity was reaching between 8 and 12 microvolts. And then on session 10, her ability to activate had increased to between 12 and 18 or even 20 microvolts. So just looking at the line graph, we can see that there's been a dramatic improvement, but adding that to the grid findings that we've just looked at, you can see that maybe the maple provides extra information to help us progress that training in a more bespoke way for that patient. Again, here you can see the progress of this same lady, case study 2 in endurance. She has improved her ability to activate, but as you can see on that right hand picture, session 10 progress, she's still using her fast fibre activation to maintain a pelvic floor hold. So we are working on that with electrical stimulation and EMG biofeedback, and also the PeriFit at home. So this lady here has symptom progress at session 10. She no longer has leakage, and she is now gradually progressing her exercise. She's starting to return to impact. Her bowel emptying now feels normal. She's got no concerns about her bowels. And because of the improvements within her pelvic floor, she's able to exercise more with a personal trainer and is gaining confidence to add load and resistance to her workouts in order to further heal her diastasis. So she's feeling a bit more confident. Her testimonial at session 10 was that she found maple a huge challenge in the beginning, but with the guidance and encouragement of her physiotherapist, she was able to persevere. She felt initially that she would never make progress and would always leak when exercising. This was tough for her, but after a few sessions she started to notice the improvements, and she is now more active than she was before the birth of her baby. So she's very pleased, but still working. Here we have case study 3, Sarah, who is a 49-year-old female. One pregnancy after a long history of fertility treatments. She was delivered by elective caesarean section, and I've added this. I know we're looking at vaginal deliveries, but sometimes people have a complex history, and the mode of delivery isn't necessarily the only reason for them to come into our clinics. She had a heavy baby of 10 pounds 1 ounce, and she also had a history in the pregnancy of very severe pelvic girdle pain. She used crutches and a wheelchair by the end. She had severe hyperemesis during the pregnancy and was on odanzatron, which affected her bowel movements as well. And for a lot of the pregnancy she was on bed rest or sat in a chair, so she was quite deconditioned by the end of the pregnancy. Another thing of note, which ties into her symptom progress, is that she is the only director running a very large company, and she's at present unable to take maternity leave and is very, very busy and is trying to sell the business, which she's been trying to do for the last few years. But that is taking up a lot of her time, her energy, and is distracting her potentially from physiotherapy treatments, which is completely understandable, but is of note. Her symptoms when she first came in was bladder urgency and urging continence. Coccydynia was her main problem, and lower back pain. Stress incontinence when sneezing and during exercise, flatal incontinence, reduced bowel emptying frequency, and dyspareunia, which is gradually improving. So here we have her 2D maple grid findings on session 1 on the left and session 5 on the right. On the left we can see that during MVC her external anal sphincter, so please note that the maple probe is now inserted rectally. So ring 6, which is the outermost ring, is the identified as the external anal sphincter on MRI scans. And we can see that her peak EMG score is 23.2 microvolts, which is very good. And on a line graph you'll see later that it looks pretty good. But her external anal sphincter on the grid is shown to be less active and quite inactive for MVC. We didn't test the endurance initially. But you can see that there is actually a reduction in activity findings by session 5. So you can see on the grid that you've got fewer of the darker shadings on the grids for MVC and endurance. Also you can see her peak score for MVC has gone from 23.2 down to 16.1. And we're looking at the reasons for this despite weekly treatments, and it appears to be the effect of pain in the coccyx when trying to activate her pelvic floor muscles. So what we want to try and do is treat the pain from now onwards, and as the pain reduces we're hoping that her activation will improve. But there's no overactivity in the pelvic floor muscles or the sphincter muscles, as you can see in the rest assessment on session 5. That grid looks normal. Her resting activity is 1.1. So this pain isn't necessarily related to pelvic floor muscle activation at rest or overactivity, hyperactivity, however you want to discuss it, but it seems to be more related to what's going on at the coccyx. So we're going to work on pain relief first and then review her maple findings. So our case 3 here, we're using maple anally. We're using initially electrical stimulation to activate rings 5 and 6 for both fast fibre and slow fibre activation, and this is all within pain tolerance thresholds. At present she's unable to activate her external sphincter herself, so EMG biofeedback at the moment is not appropriate. We're focusing on electrical stimulation. She's also using a Kegel 8 machine at home rectally to try and promote external urethral external anal sphincter activation. She is finding that hard to fit into her daily schedule. And you can see here the similar findings there, that on the line graph on the left compared to the right, she's able to achieve higher activation levels on the graph, and that has dropped away, and her ability to release has also dropped away. So her offset is a lot slower than it was before. And the same with her endurance findings, that on assessment she was able to squeeze and hold using some fast fibre now and then, but this was more of a struggle at session 5 for 30-second holds, and the main reason we think is because she's feeling pain and discomfort when squeezing, and so is easing off the activity within the pelvic floor to enable a reduction in pain. So here we've got her symptom progress, so looking at the subjective findings. Her bladder is less of an issue now. The coccydynia and lower back pain has increased. She sat awkwardly on a hard surface recently, and that's flared up and aggravated her coccyx pain. The stress incontinence is ongoing, but she tends to avoid the aggravates where possible. Flatal incontinence is still a problem, emptying her bowels more regularly, which is a good thing, but dyspareunia is less of an issue now. So there are some improvements and some things that are the same and one thing that's worse. Her testimonial at session 5 is that she's so pleased to have found a specialist using the device like Maple. She knows that it will be pivotal in her rehabilitation. She then confesses that she's thrown everything at this problem, but now understands that sometimes less is more, and pushing dysfunctional muscles too hard can actually cause a prolonging of the rehab process, and that relates to her using her Kegel 8 machine 3 times a day and possibly over-tiring the muscles. She's looking forward to seeing and feeling her progress in the near future. So we've got a little bit of work left to do with case study 3. And finally now, case study 4 is Chloe, a 32-year-old female. She's had 2 pregnancies and 2 deliveries. Her first delivery was a 4th degree obstetric anal sphincter injury, which was surgically sutured, and then a 2nd degree SVD, so spontaneous vaginal delivery, with a 2nd degree tear the second time round, which was about 18 months after the first delivery. Her main symptoms on initial assessment were flatal incontinence. That was her main issue and the reason why she came to physio. She had bowel urgency daily, fecal incontinence about once a week. Prior to her pregnancies, she's always had a weak bladder. She was always rushing off to the toilet, and noticed frequency as well as urgency. Since the deliveries, she is noticing incomplete bowel emptying. About 2 times a week she feels normal, but the rest of the time she's struggling to empty. So again, we're looking at this lady with a rectal insertion or an anal insertion of the Maple probe. We've got her session 1 on the left and her session 6 on the right. You can see that on the left, the rest assessment, far left grid, is showing increased activity at rest of 7.2 microvolts. So anally it should be 3 or below. And you can see there that the darker shading is in the area of puba rectalis, mainly on the right and the posterior plates. During MVC, she's able to activate everything very well, apart from the external anal sphincter, which ties in with a lot of her symptoms, and the same with endurance. She can reach good microvolts, good peak EMG, but that peak EMG is not coming from the external anal sphincter. So we've done 6 sessions, and you can see the changes on the right-hand set of grids. Now the resting activity has come down very slightly, but not much. So it's gone from 7.2 to 6.5 microvolts, which isn't really significant. And she still has issues with incomplete bowel emptying and sensations of constipation. So that's something that's an ongoing treatment strategy for us. However, you can see during the MVC and endurance findings on the far right that her activation of the external anal sphincter is improving. So her peak scores have increased slightly from 21.7 MVC to 24.9 MVC, and then 19.5 endurance to 25.1 endurance. But the main thing is that ring 6, the outer ring, on the grid, you can see that there is a darkening in the shading, which is showing an increase in the activation. So she needs to simply continue with this to improve her functional control of the bowel. So this lady's treatment programme for case 4, we started with electrical stimulation specifically for rings 5 and 6 on both fast fibre and slow fibre settings. And the electrical stimulation was combined with manual therapy rectally to release any tension through puba rectalis, as we found on EMG findings, and we used EMG biofeedback to improve her ability to activate the external sphincter and also release puba rectalis. We've progressed to release work to function when she's sat on the toilet. So when she's trying to empty her bowels, we've gone through defecatory dynamics, positioning on the toilet, breath work, and release strategies to help her empty her bowels more effectively. We've also referred her to our dietitian to look at her diet and fluid intake. Her current stool type is 1 to 2 on the Bristol stool chart. So we're trying to improve her stool consistency to also help with the bowel function. However, client has put the physiotherapy sessions on hold now. She's under the investigations of the colorectal team, and she is going to get in touch with us once that's all completed. So here you can see the changes on MVC, so the fast fibre activation from session 1 to session 6. And there's an improvement in her ability to activate the pelvic floor during a 3-second window. There's also a slight reduction in the resting activity in between contractions. You can see that there's an improvement also in her ability to use the slow fibre muscles within the anal canal, but there is still work to be done. And in terms of her symptom progress, she no longer has flatal incontinence. The bowel urgency has gone from daily to just a few times a week. Her fecal incontinence is no longer an issue. She hasn't leaked feces for the last few sessions. Her weak bladder feels improved also, but the main issue now is incomplete bowel emptying, and she is going to return for ongoing release work of puba rectalis, either rectally or vaginally, with or without maple, depending on how she feels after the colorectal investigations. So her testimonial at session 6 is maple has been useful in reducing some of her symptoms over the last 6 weeks. She's waiting further investigation for bowel function, so she's going for a colonoscopy, transit study, and defecating proctogram. She feels more confident now because she's able to maintain control, but the incomplete emptying of the bowels is something that she really wants to resolve in the coming weeks and months. So just in conclusion then, at the end of this webinar, we can see hopefully that maple is a useful part of the rehabilitation toolbox following childbirth. So we've seen various deliveries, various reasons for the pelvic floor dysfunction, and various pelvic floor dysfunctions as well. And we've also seen how maple has affected the pelvic floor dysfunctions, how symptoms have improved in the majority of cases. We've also seen that maple could be a useful tool to screen for present and potential future pelvic floor dysfunctions. Now, in an ideal world, we would use physiotherapy assessment, including maple and other elements of the toolbox, to assess every woman postnatally, whatever delivery type they have had, to screen for any potential pelvic floor dysfunctions. However, this is in the ideal world, and resources are thin on the ground in so many cases. So using the risk factors that we've seen from the NICE guidance to filter priorities where capacity doesn't allow for full screening of everybody can be useful in just identifying those who are most at risk of future pelvic floor disorders, whether they have symptoms or not, immediately after delivery. We've also seen that maple is accurate, it's detailed, and it's bespoke. And this is something that is brand new on the market from what I can tell from my experience, and it helps me in my clinic to provide a more in-depth assessment and treatment strategy for my postnatal clients. But Maple does not overcome human factors. So if you have a patient who is non-compliant, if you have someone who is distracted from treatment, all those human factors that can limit rehabilitation in any other case will be the same for Maple. So it's really important that the therapist uses their skill as normal to overcome those human factors, those lifestyle issues, those distractions, to enable the patients to overcome those factors and to complete the course and notice the treatment benefits. So here are the references that I've used at the beginning of the webinar. Feel free to take a look at those. And I really want to thank you for listening to this webinar. I hope you found it useful. As this is a webinar that's been recorded, there's no option for live Q&A, but if you do have questions, please contact Maple and they can forward those questions to me. I'd be more than happy to answer any questions or have any discussions with you. But I hope you have a lovely rest of your day. Thanks for listening.